Hi, everyone. I'm Bunny Ellerin, and I'm the president of New York City Health Business Leaders. And this is, welcome. This is the first in what will be a periodic series this summer where we look at the new normal, or maybe the not so new normal, but it's the new normal following the past 4 months. And as it relates to our health ecosystem. And as is usual for New York City health business leaders, we'll be looking at a range of topics in a range of sectors. But for the first one, I couldn't think of a better topic than thinking about how to restore our health system. And so I want to thank Clarify Health for suggesting the topic. And also for working with us on it. Obviously, New York City was the epicenter of COVID, and our hospitals, physicians, nurses, the staffs were really the hardest hit on the front lines, obviously the patients too. You know, and now as COVID begins to ebb in New York City, we're seeing some of the effects, and our health systems were really hit financially. You know, one, there was a lot of increased expense with PPE and personnel, but there were also a lot of delayed procedures and lack of office visits. You know, people were told to stay home. So today we're going to talk about the impact of COVID, how we restore some faith back in the system, so the role that telehealth has begun to play a bigger part in. And so with that, I wanted to introduce our guests. First, we have Emmy DeLand, who's the Senior VP and Chief Strategy Officer of New York Presbyterian. Next, we have Dr. Richard Morrell, who's the Chief Physician Executive at Caremount Medical. And we have Dr. Ryan Ahern, who has two roles. He's an internist at Weill Cornell, and he's also the head of corporate development at Clarify Health. So welcome all of you, and thank you for making time today for this really timely and important topic. So I thought first we could just briefly go around, just tell our guests a little bit about your role, what you do. So Rich, maybe we'll start with you.
Sure, thank you, Bunny, and very happy to be here. Thank you for the invitation. So I'm an internist, similar to Dr. Ahern, and I mean, I forgot to mention to you, I actually started my career at New York Presbyterian, Columbia Medical School, residency at Columbia, and actually worked there for 10 years after residency. So I'm the Chief Physician Executive here at Caremount. Basically, that includes all aspects of general physician management, as well as strategic growth of the organization, and a medical director for ACO. So the clinical side of all of our at-risk and population-based services. For those participants who may not be overly familiar with Caremount, we're the largest independent group in the country right now. We have 500 physicians, about 120 APPs. We extend all the way from Manhattan with the old Murray Hill Medical Group. We have about 50 providers in Midtown Manhattan, all the way up to Kingston and Rhinebeck, New York. It's about a 120-mile span. We are really outpatient only, although we have a lot of docs who do work only in hospital systems, but primarily an outpatient practice, multi-specialty group covering pretty much every specialty, and have in-house lab, pathology, radiology, all on one EMR.
Great, I didn't know you were the largest. That's impressive. So Ryan, why don't you go next?
Yeah, hi everyone. So my name is Ryan Ahern. I lead corporate development and data strategy at Clarify Health. So I look after a number of our both organic and inorganic growth initiatives, and I also manage all of our data partnerships. As Bunny mentioned, I also am a practicing physician. I'm an adjunct physician at Weill Cornell, where I practice as a hospitalist, caring for inpatient patients. And very relevant to this conversation today, I ramped up my clinical time pretty materially over the past few months was working on the front end of the surge when we were literally meeting about the number of ventilators we had left and the number of patients who needed them, in the middle or back end of the surge when we were seeing very complicated patients coming out of the ICU. And I was on service last week in the hospital, did not see a single COVID patient, but did see some patients with complications that were potentially related to some of the deferred care over the past few months. So I'm super excited about this discussion today, to talk about sort of what we've all learned so far and what we have ahead of us.
Great, thank you, Ryan. And Emmy.
So eager, I almost started talking when I was muted. Hi, well, it's a privilege to be on a panel with Rich and Ryan and with you, Bunny. I am the Chief Strategy Officer at New York Presbyterian. We're about a 4,000 bed, but at the height of COVID, we were almost 7,000 beds. Hospital, we had at one point 20, almost 600 COVID patients in the middle of April, and almost 1,000 of those patients were in the ICU and on ventilators. My normal role as the Chief Strategy Officer is to do service line program planning, very much involved in the Center for Innovation and Telehealth, involved in the bringing up of our ACO, very much involved with trying to figure out what the future is post-COVID, and very pleased to be here.
Well, thank you. So one program note for everybody. I'm sure you're going to have a lot of questions, and we are going to take your questions, but please put them in the Q&A box and not in the chat box. So, Emmy, you were just talking about NYP. I read Dr. Craig Smith's emails. So Dr. Craig Smith, for those who don't know, is the chief surgeon or the surgeon-in-chief at NYP. And he wrote an email every day during COVID to the staff, and they published these emails. They were incredible, really touching, moving, and just absolutely showed the enormity of what your system and people were going through, and really what everyone was going through. He stopped a couple of weeks ago, and so now that we're on the other side or getting to the other side of COVID, Emmy, what are some of the big lessons that you took away from this experience?
So I think the first isn't so much a lesson, but it was to see the incredible way that a very complicated enterprise, because needless to say, we are affiliated with not just Weill Cornell Medical School, but also Columbia. And to see three organizations working almost seamlessly through pretty horrific times, and seeing everyone to their max contributing to try to help. You know, it's the front line, but behind that front line was a cavalry of people making sure there was food, making sure there was scrub suits, making sure there was testing equipment, making sure there was strategic supplies. So the amount of fortitude and courage that the entire hospital showed is just amazing. Having said that, putting us back together is more challenging than it was during the immediate COVID surge. But there are several lessons that we've learned. One is we need some more space, flexibility to be able to increase our ICU capacity. We more than doubled it, and we need to have that flexibility moving on. That includes actually being able to flex up the sizes of ICU as well as EICU. Second, and obviously, we've been involved with our telehealth program. I think it was probably the largest telehealth program in the country then, or as I call it, BC, before COVID. I think now it has really up to I think 90,000 visits. a month, and I think that is totally going to change the way we deliver care. And it's still being titrated, and there's a certain amount of recidivism now that you can see it in person, but telehealth across the board in terms of consultation, in terms of creating remote monitoring capabilities. We're just beginning to be able to understand the magnitude. That's assuming that reimbursement doesn't
Right.
go away. And then there's remote work. I think that all of us, I'm in my office today, but there's a huge number of us are working remotely, and I think that needs to be determined how we refashion our workforce and where they work and how they work. And then last, there's two more. There's supply chain. Clearly, we were caught, like most of us, not prepared for a pandemic. We were prepared for emergencies, but nothing like having to go from 4,000 masks a day to 100,000 masks a day. So we have to change our whole inventory approach. So just in time, it used to be the mantra. Now it's a little bit more like just in case of a pandemic. And we are in the midst of creating storage and acquiring PPE. And then lastly, upskilling or cross-training. We need to have more flexibility to be able to have better capability for some of the skills of ICU nurses to be med-surg nurses be able to have it, doctors being able to flex up to ICU, and the emergency room having more flexibility as well. So sorry I went on so long. Don't ask me from now on.
No, those are 5 key learnings. Rich, what about you? I mean, you're in a different scenario, right? You're in a medical practice. So what did you take away?
Yeah, so we didn't have the same stressors, and we're very grateful to our inpatient colleagues who really took the brunt of caring for the sickest of patients. I think some of our key takeaways, the biggest one, and I think this is a known one, but reinforced through COVID, is communication and the importance of communication through a crisis. So some of the things that we did, we had evening calls across our entire organization in different sectors. We would have, physicians, APPs, staff, and the way we would set it up, because you can't have 1,000 people on a phone call and have it be effective, but we would give different presentations from our CEO, from myself, from our chief nursing officer, from our chief safety officer, updates on what was going on in our organization and outside, and then receiving questions just like this in a chat box or a Q&A, sorry, not the chat box, a Q&A, and answering them. And we did this every night with different sectors of the group. I think to reiterate some of what Emmy said, we were quite lucky that our chief safety officer was a bit of a prepper beforehand and had prepped us when the first SARS came out. So we were well supplied with PPE, but I agree you can't have enough. I think taking the opportunity now, never let a good crisis go to waste. We are rethinking some of the way we do business. So also telehealth, we've had a telehealth platform for 3 years, which was minimally used, mainly because it was the cost and it wasn't reimbursed by insurance. That took off, and we were doing from a handful of visits to over 1,500 a day. That's now decreased, and it's we're averaging about 600-700 a day.
Mm-hmm.
But it's an opportunity. Physicians, providers love it. Space is one of your largest costs for medical providers. We have some offices where a provider net will now do 1 day from home doing telehealth. It eliminates commute. It eliminates that we can give that space to somebody else who needs those for in-office visits. Slightly lower staffing costs. You still need staff for phone and stuff like that. And we're doing the same with a lot of our support staff. Certainly the back office support staff, and even some of the clinical. And I think that's been a huge positive to come out of this.
Absolutely. And we're definitely going to talk about telehealth.
Mm-hmm.
But Ryan, you were on the front lines, yes?
Yeah. Look, I think I would second and third everything Emmy and Rich just said. I guess I'll just quickly say, probably the biggest learning for me, this is going to sound a bit soapboxy, but potentially naive, but look, it's on us. So that was my biggest learning. There's no magic savior that's going to come. That was particularly evident with the lack of leadership from the federal government. It's up to providers and health plans and life sciences companies and health technology companies and the frontline workers, and as Emmy said, everybody that's behind them, to come together. And I think, at least in my lifetime, it was the first time I saw a response like that. And my hope is that we can stay together, because I frankly don't think that this journey with COVID is over.
As we're seeing in other parts of the country.
Yeah.
And so, you know, we're obviously a big outcome was the fact that a number of surgeries were delayed and visits, even though telehealth was there, were delayed. So we're actually going to do a poll with the audience before we start talking about it to see what they think in terms of the patients who had their care deferred due to COVID-19. What proportion do you expect will experience meaningful negative clinical consequences? And we are getting a lot of voting. This is cool. Very cool. All right, we'll give you about 4 more seconds. Okay, all right, I think we are gonna end. All right, so here's what our audience thinks in terms of the negative consequences. The vast majority, somewhere between 25 and 50%. So this is very, very interesting, and I think I would have probably said the same thing. But I want to bring up something that I read yesterday in the New York Times. It was an op-ed columnist, Dr. Sandeep Johar, who writes frequently for the Times, and his op-ed was, "People have stopped going to the doctor and most seem just fine." So his thesis was that there's a significant amount of unnecessary care or care that, or over delivery of care. And so would love your perspective on what this means in terms of the deferred. Rich, do you want to?
Yeah.
Oh, no, Ryan, please go ahead.
Yeah, I mean, I was just going to say, I wasn't able to vote, but that's probably the answer I would have given as well. Look, anyone who works on the front lines in healthcare can tell you that some meaningful proportion or segment of utilization is unnecessary. My push is that I really think the devil's in the detail, right, in terms of what's unnecessary versus what will have meaningful consequences. And it's going to vary greatly by disease type, by patient population. And my hope is that COVID can be a great case study for us, and that we're capturing the right data and conducting the right analyses to determine that level of nuance, so that we can hopefully come to a place where we have a rebound in the care that was necessary, and that we can more permanently cut out the unnecessary care that previously existed.
What was hardest hit, both Emmy and Rich, in your respective institutions, and where are things now? Because we've been open, I guess, a couple of weeks where we've been allowed to do procedures.
Yeah, so our biggest were GI, which makes sense, procedures, dermatology, ophthalmology, and orthopedics were the biggest. The least hit was oncology, internal medicine, cardiology. So you're more kind of chronic medical conditions. So I think, you know, certainly from some of the stuff that we do is unnecessary medical care. Some of it's just unnecessary. Some of it, the tincture of time will work and people will be better with time. For instance, meniscal knee surgery, the literature on that says patients 1 year out are the same as they were if they have surgery or if they just have PT. So certainly there's going to be no difference there. But I do think, there was also an article in the Times a week ago from the CEOs of both Cleveland and Mayo, who said they expect potentially more people will die from fear of COVID than from COVID. And they didn't really cite where their data was from, but missed cancer diagnoses and deaths related to that. So we are quite worried people missing mammography screening, colon cancer screening, low-dose CT lung cancer screening is going to lead to issues.
So what steps did you put in place during COVID in terms of tracking these patients?
Yeah, so we are lucky. We have, because of our pop health team, we have a very robust analytics team. So we've done a number of things. We looked at canceled appointments, and we use Salesforce as our patient outreach tool. And for appropriate visit types, we did an outreach for a televisit for these patients. We've looked at, from health maintenance, people who are behind on certain screening procedures and doing outreach to them. So like one of the big ones that's ongoing right now, pediatric vaccines. We looked at children 5 and under who had missed a vaccine. And we had about 20% of our children 5 and under who were behind now on a vaccine. And I saw quotes up as high as 40% down in New York City. And we've now done outreach to the parents, and we've supplied the pediatricians with their list of patients who are behind in an effort to get them back in so that we don't see an outbreak of measles here, in 6 to 12 months.
Yeah, just what we need.
So the only comment that, because I think both Ryan and Rich said everything that I could have possibly thought of, with one exception, which is at the height of COVID, there were 200 deaths a day at home, as opposed to 20 deaths a day that was normal in New York City. So there is clearly a death from COVID-related either fear or from COVID that was not being appropriately tested or treated. That has reflected in the numbers on our emergency room in reduction of heart and stroke patients. And that number, whereas it's improved in terms of the number of patients that are coming to our ED, it is still significantly lower than the numbers in January or February. So I think there continues to be a fear to going to the hospital that is increasing the potential death rate from non-COVID related illnesses. But I think that telehealth played an enormous role in probably reducing the number of the consequences of the deferred care. But it's too early to tell, and we're doing lots of studies to look into it. But judging from the physicians I've spoken to, there are cases that deferred care has been problematic, but there have been many cases where it doesn't look like it's problematic yet. So I don't know whether I would have said 25 to 50%, Bunny. I'm not sure I would have been that high in terms of what I think the downside is.
And what is NYP doing to communicate with people that it is safe to come back? Or is that a much bigger, that's not a media campaign, but.
Well, I think if you've been, Greater New York has had a campaign over the last week, and we've had campaigns, and so have our competitors had campaigns to assure our patients and prospective patients that it is safe to come back to the hospital, and it is safe. And we've been doing significant amount of communication with our patients. Obviously, the most successful communication is doctor to patient, and that the doctors have been calling their patients as follow-up to secure. We're doing a lot, internal to make it safe for the patients to come home, which I'm glad to discuss if you're interested.
Yeah, we will get there in a minute.
The one other thing I'd say on this, Bunny, is if you look at the detail of the poll or the survey that was done by the Kaiser Family Foundation that was sort of prompted the article in the New York Times that you mentioned, it says that 60% of patients that deferred care plan to, quote, make it up over the next 3 months. So I think that even without the outreach, I think there are a lot of people that were maybe pushing things back, maybe pushing back their colonoscopy or their mammography or whatever it was, but greater than half of them intend to come in, at least according to that survey.
Right. But Ryan, I mean, you and I, we've spoken before too about, should we even expect that the level will be back at the same rate that it was before COVID? And maybe it shouldn't, right?
Yeah, no, that's exactly right. I think we obviously saw for non-COVID illnesses a huge decline in utilization. Pendulum clearly swung too far. That was a very impressive statistic that Emmy mentioned about the number of at-home deaths, right? And it will come back through a combination of outreach from providers and patients knowing they need to come back in for their screening and or having a consequence of the deferred care. And the question is, does it come back to where it was, or does it settle out at some decreased run rate? And I think, Emmy, you were saying the other day that in NYP's scenario planning, you're expecting non-COVID utilization to rebound, of course, but not necessarily to return to pre-COVID rates. Is that right?
Well, I think that it will take time for it to rebound, and then it might not, because of the remote monitoring at home might take care of patients. I think technology can play a significant role in reducing the hospitalization rate.
Yeah, I agree with that. I think we are not anticipating a full 100% return back. I think you're going to still have some people afraid. I think televisits are going to replace some in-person, a significant number of in-person visits. There are also challenges under the post-COVID. We are not able to do colonoscopies and endoscopies at the same rate that we were before, because you need to leave the room idle for 20 minutes if there's any aerosolization. So we're anticipating, at least for this year, we will not hit 100% of pre-COVID.
Yeah.
So everybody mentioned technology.
Yeah, just so you know, we have to keep a certain percentage of our beds free for when the next surge happens. So that certainly plays a role as well. Sorry, Bunny.
No, but actually, so on that point, I was going to ask, how, people think maybe we're going to have a second surge in the fall. And so how are you preparing now for that? So you already said one way that you're preparing. And actually, what are your predictions, if you're willing to say?
So that's my question. We're predicting that when fall resumes, and assuming school comes back, there'll be a mini surge. And we're also predicting another mini surge in December. That is based somewhat on what happened with the pandemic of 1918. It's a little bit on what happened with Wuhan. It's also about just patient flow, but neither of the surges will be anything like, we will not be the epicenter of the surge.
Yeah, I agree with that. I think we are going to see an uptick, especially what we've seen across the country. But I think New York will be prepared so we don't hit, the crisis level that we hit before.
So telehealth was the breakout star of the past several months. Some people say more happened in 10 days than in 10 years, right? In terms of getting reimbursement, credentialing doctors across state lines. So talk a little bit about the role telehealth played for each of you, and then what role you think it's going to play going forward. Ryan?
Yeah, so the caveat for me is that because of my inpatient scope of practice, I was not caring for any patients via telehealth. We were using, I think, very effectively telehealth and FaceTime-like communication technologies in patients' rooms to include their families in discussions. And for particularly vulnerable and elderly patients, that's actually a pretty critical part of care. And my expectation and hope is that will continue post-COVID to the extent that patients' families are unable to get into the hospital physically. I guess I have two reflections or hopes for the future of telehealth. One is, this is very similar to my utilization commentary, is I think it's going to be critical to capture the data and analyze and understand outcomes for patients that have received telehealth versus inpatient visits. There are going to be certain diseases, patient types, et cetera, that it will fly with and certain won't, and we need to really know that in a data-driven fashion. And then second, and I would actually love to hear Rich's thoughts on this, is it's for, I think, the long-term sustainability of telehealth, it's going to be critical that it's actually replacing in-person encounters. Because if you think about it from a payer's perspective, they're only going to really be interested in reimbursing it in the long run if it's somehow averting what would have been a higher cost in-person visit. So I think it's on providers to be tracking that and ideally accomplish that.
So Rich, what do you think?
Yeah, I agree. The preliminary anecdotes I heard from the payers was they were concerned about paying for it prior to COVID because it just led to increased costs. In many telehealth visits, someone had a sore throat, telehealth visit said, well, you got to come in for a strep test. And it was 2 visits instead of 1 and double the cost. I think there are unique opportunities for it when used appropriately, and certainly by specialty. Ophthalmology doesn't really lend itself very well to telehealth, but endocrinology does. And you can do, certainly diabetes management likely better via telehealth than you can in person. You can do a med-rec better via telehealth than you can in person. So instead of just going down the list of meds, you can have the patient have their bottles there and show you. So, at our peak, it was over 50% of our visits. Now it's about 10%. I'm not sure where it will settle out. It's actually lower already than I thought it was going to be. I think it also has a unique place for homebound patients. So we're doing a model that don't take credit for. Henry Ford did this model, and they have many places do home visit programs, but they are expensive to run. So because you have an APP or an MD going out to the home, what they've done and what we're doing now is you have an MA level person go out to the home. They're able to, the travel time is then on them. They take an iPad device, they take a home physical exam kit. They do the visit with the doctor who remains in the office. And you can have several MAs going to several different homes and one doctor doing these visits, or you can do them with a primary care doctor. And I think it's a nice financial model where it's much lower cost and it provides high quality care right in the home.
Have you seen any difference by age group in terms of our older patients coming back more than, or were they receptive to telehealth?
We have not. Telehealth was adopted across the board, no matter what age.
It's really interesting. Amy, how about at NYP, which has one of the largest programs?
Well, we saw a V-shaped curve like everybody else did the day that the ambulatory practices closed. And we saw it across the board, but like what Ryan and Rich said, it works better for some specialties than other. But I have an orthopedic surgeon for her husband who, despite my pleading, had never done a telehealth, and he did several telehealth for foot and ankle injuries. And it was pretty effective in terms of seeing which patients really needed to be seen and which ones could wait. I had the rheumatologist who had never tried telehealth, who actually thought that it was quite effective, and is continuing. Both of them are continuing to use telehealth. I think that there's because of the 3 months that you really couldn't see a physician, I think there are lots of patients who have waited and would like to see a physician in person. And I don't think we've fully seen what the balance is between ongoing care that's going to be a telehealth visit and then how often you really need to see it in person. My mother, who's 99, had a spine issue, and she was seen through telehealth and had an MRI and didn't have any advance in person with the physician before a procedure was done. So I think that we do have to be careful that it doesn't become an additive, but I think you can easily, effectively, what we found, weed out those patients who really need an intervention and those patients who probably don't. And so I think it remains to be seen. But apropos to what Rich said, I think what we can do remotely is just beginning, and we still have to work out what that care model is going to look like.
Well, on that note, we have a question from the audience who thanks you for your support of tech innovation. And do you see an appetite for patients to pay a monthly fee to streamline remote monitoring and reduce friction care?
Well, that's a very interesting question, because that would be, what is that price point and how much of it's going to be covered by third party? And I think some of that remote care is going to have to be a family decision, because a lot of what will make it very attractive is the idea of having to take time off to take a family member to the doctor to then take them home. If remote monitoring is effective, it might be very cost efficient to provide it.
So we're going to do a second poll. And this one is on what is the highest priority area of investment that health systems should make to come out? I typed this, so I did it wrong. That what should they make in order to come out of COVID-19 stronger? So highest priority area of investment. And we'll give folks a couple of seconds. And while we're doing that, please send in your Q&A on the Q&A chat or the Q&A box so that we can start taking those. All right. Okay, I think that we are going to show. Well, all right, here we go. Technology, not surprising. Patient outreach and engagement is number 2, value-based care 3. Interesting. So no, I'm not surprised on technology. I do want to talk about patient engagement and outreach though, and in particular, Rich, telehealth requires, I think, a different set of skills than potentially an in-person visit. And so many doctors were just thrown into it. Mm-hmm. Do you think that, so what do you think is one, should there be additional training, right, for doctors? And 2, what do you think that's going to do to the patient-physician relationship?
So you do need additional training for doctors, and 2 sides of it. There's the technical component for how to actually use the system, right, and then access the appointment. And then there is a training of honestly a risk management or med management about what is appropriate over telehealth and what is not appropriate over telehealth. So when we have done that, we want people to use telehealth in an appropriate manner and not go beyond the limits of what it should be, and put those themselves, the organization and the patient, at risk. So there is additional training on that. And there is some training for patients on that, although that's honestly a little easier because you can always initiate almost anything via telehealth visit and then convert it to an inpatient visit, tell the person you need to come in. Unless, and this would be no different if they were to make an appointment online or call and schedule, if this were an acute emergency and they schedule a telehealth visit and they should actually be heading to the emergency room.
I mean, how do you train your physicians? Do you train all of them?
It's interesting that you asked that question. We had training that we started, I don't know whether it was 9 months ago, a year ago, where we were training groups of physicians on a weekly basis. And yes, we were not, it was not mandatory training, but we were training large groups of physicians on a continuous basis. So, and that training just became more intensified once COVID started to surge. But there is training that needs to, and I agree with what Rich says, there is the component of just the technology, and then there's the issue of them being able to help their patient get to the right part so that they can help with because after all, the patient has to play a more active part in the diagnosis. And I think that requires some amount of training on the part of the physician.
Here's, we have a question from the audience. Lori Evans-Bernstein. Hi, Lori. What's being done to proactively identify patients with chronic conditions? What steps are you taking?
So we were quite concerned through COVID and post-COVID, and this was seen in areas like after Hurricane Katrina, where people did not have access to care, their medicines, proper diet. There was a surge in the complexities of different diseases, diabetes, hypertension, CHF, COPD. So we did an analysis and a risk-based analysis to our highest risk patients for deteriorations of their chronic conditions through the COVID time period of maybe not being able to get to the pharmacy or afraid to get to the pharmacy, and changes in diet. And we did an outreach to them initially, a technology outreach through, with an email and a link for a telehealth visit, and then actually using our care management team just to do a phone check-in. How are you doing? Do you have your medicines? Do you have appropriate access to food? Are you having any symptoms? And we've touched, I believe, about 12,000 patients with that program right now. And we don't have any data to support that it was effective, but I'm quite confident that certainly from a patient experience viewpoint, we got a lot of positive feedback that, we were concerned about them. And I am optimistic that it did prevent some of the exacerbations of chronic diseases.
Interesting.
I would agree with everything that Rich says. We did the same thing, and I think I can't tell you the number, but it was for all of our chronically ill patients. We had outreach between the doctors and the care coordinators and the healthcare navigators.
And with that, I mean, just anecdotally, you find things. So, we identified a patient with atrial fibrillation who was on Coumadin. That is a blood thinner that needs monthly monitoring. And she came up as a flag because she had not had her INR and was afraid to come into the office to get her blood drawn. And we were able to send somebody out to the house to get that blood sample obtained. And if, the INR is to drift out of range, the patient's at increased risk for stroke. If it's too low, if it's too high, they're at bleeding risk.
So what are you doing now to plan for the future? Whether there's a small surge, a large surge, getting patients back, telehealth, what are some of the concrete steps you're taking?
So there's two sides to that. One is, what are we doing to get patients to feel comfortable, as we call it, the renew stage? And that includes significant patient communications, including the media, but also calling patients, as I said before. The second is doing, minimizing the amount of, there is no paperwork going on, and it's all being scheduled online. And we are obviously mapping out so that the elevators won't be overcrowded, that there will be nobody in the patient waiting rooms in there. So there's significant scheduling complexities. We have COVID testing across our enterprise that's available for our patients and our visitors, and there's contact tracing that we're supporting. And then there's obviously patient and staff safety, and that's all about masks and hand washing. And that is a significant, probably the most important piece of our preparedness is about hand washing, masks, and being socially distanced. We have e-check-in so that people are checked in before they come in, so there is no registration. And we have we've started, it's not complete, but we've started the cohort diagnostic testing. So if you come in for your imaging, you'll have your lab tests, you'll have diagnostic tests at the same visit, so that we're trying to minimize the amount of contact the patient has to have.
Yeah, that's great. Emmy, I agree with everything you said. We're doing a lot of the same of it. I will say we have one benefit to having our offices in the suburbs. So this is other than our Manhattan offices. We do have the ability to have people wait in their cars instead of waiting rooms and text them when it's time and they're ready to be seated and go in the exam room.
It's a good advantage.
That is a good advantage.
Emmy, you mentioned the increased bed capacity. I imagine that's probably both ICU and med-surg beds. Is that a decision that NYP made independently? Is that something that the state or the city is enforcing on all hospitals, or how's that decision being made?
So that decision was made by an executive order by Governor Cuomo. But before he made that decision, we had already decided to close all elective surgeries so that we'd be able to expand our ICU and bed capacity throughout all of our procedure ORs, recovery areas, and the like. I think he did in the third week in March, he gave that executive order that we had to increase our capacity for ICU by at least 50%.
But is that expectation coming from the state government going to continue through the fall and coming winter? Or?
The way that it's being positioned is that we should expect to have 30% of our ICU capacity, med-surg capacity available at all times. So for a potential surge, which in necessity could mean that we would need to, since our ICUs are full all the time, if we're at full capacity, we'd need to increase our ICU capacity by 30%. And we've made plans to be able to increase our ICU capacity without having to use operating rooms or procedure rooms.
Here's a really good one from the audience. What has changed permanently? What are we not going back to? Will waiting rooms ever be the same? Will this help us reduce the burden for other infectious diseases like seasonal flu? Thoughts on that?
Well, the first thing is I think we have to seriously think about our visitation. I think we need to seriously think about the single bedded rooms versus the double bedded rooms. We are still a state that, because of earlier decisions by the state health department, we have more double bedded rooms than single. So I think we need to think through. I think, again, I'm sorry to keep on going back. We need to leverage the use of telehealth to keep people out of the hospital, either, through remote, hospital at home type of situations, but keep people out of the hospital setting. And I think what's gone forever is the issue, whether waiting rooms will be gone. I think paper should be finally gone, which has been in my lifetime always just around the corner. And I think that is a permanent change.
Yeah, I agree. I think paper will be gone, which is fantastic. Been pushing for that for over a decade. Telehealth, again, is here to stay. It'll be interesting to me. One thing we're trying to predict is what effect will this have on the flu season, particularly flu shot. And, We actually significantly increased our order for flu shots this year. We are anticipating that more people will be requesting it, which would be great and decrease the morbidities from the flu. Will that actually pan out, or will people be afraid to come in and get a flu shot? I hope not.
Do you still have a fax machine in your office, Rich?
I do not.
No, but I mean, that will be the greatest time fax machines are needed. So Ryan, you work for an analytics company. Analytics have been front and center in discussions pre-COVID and during COVID. Obviously, they're playing a huge role. So what are you seeing in terms of analytics and maybe what other systems are using it for?
Yeah, so we're kind of seeing three big themes from our provider and payer customers, and this is not just in NYC, this is nationally. The first is around provider networks and referral patterns, the second is around value-based care, and the third is around payer networks. So for the first, look, if you take it as a given that utilization and therefore volumes they're going to rebound some from where they dipped to, but potentially never going to make it back to where they were pre-COVID for all the right reasons that we've been discussing, then the sense of urgency for providers to understand the fidelity of their networks and their referral relationships that drive volume for them is going to be increased. The competition for physician alignment that already existed in competitive markets will only be increased. And so we're hearing that a lot is on the mind of our provider customers. The second, like I mentioned, is on value-based care. Look, in a traditional fee-for-service environment, right, a decrease in utilization, the vast majority of that value that's created by the decrease flows to payers. And providers are smart, and I think a lot of our customers, our provider customers, expect to be increasing their focus on value-based care to help capture some of that value going forward. And the additional nuance I'd add to that front is some of the cash flow problems that providers are seeing with this decreased utilization, the extent to which they're executing value-based care contracts that involve upfront payments, more on the capitation end of the spectrum, that can help solve cash flow problems. That's something that we're hearing. And then finally, on the payer side, look, if unemployment rates don't rebound dramatically and quickly, that means, right, for at least the short to medium term, if not the long term, there are going to be less people on employee-sponsored health plans. There are going to be more people on sort of ACA or individual exchange type plans. And payers are thinking already about designing and optimizing networks to serve those populations.
Staying on the payment issue, both Rich and Emmy, you have ACOs, right? And doctors did get hit. The ones with good value-based contracts had money coming in. So what are your thoughts on ACOs post-COVID?
So I've been working in ACOs since they first started. And what's interesting, trying to stop people from going to the ER, lower inpatient stays and post-acute, nothing was ever as effective as a pandemic. Lowered those numbers by 40 to 50%. I think, our analytics team is looking at this, but the predictions are that ACOs and MSSPs will do extremely well this year, and that the decreased utilization is going to be far from offset by any increased COVID costs. CMS is clearly expecting the same, and they've probably modeled it out as such, because they've approached to put a 5% cap on savings. And there's some give back on that on some of the quality metrics, since it's going to be harder to meet the quality metrics. I think it is a great year to be in an ACO as a hedge for the fee-for-service world. The problem is really the timing on ACO payments. If it were truly capitated, you know, we're full risk for Medicare. It's 30,000 patients. It's a $350 million a year plan. If we were getting a check every month for that, and we could offset our monthly expenses that way, it would be one thing. But our savings that we're accruing right now, we will get paid in October of 2021. So from a cash flow and a cash accounting standpoint, it really doesn't help you, you know, to get through a time.
So Rich said everything I could have said and much more articulately. And for us, you know, it's 50,000 lives. So it's still a very small piece of our business. It's very important because we've been very successful at it, but it's a very small, and we don't get paid till next October, and ours is downside risk only, or upside risk only, sorry.
Got it. So we have a few minutes left. I wanted, you know, you've all been in the trenches. So what's something you're hopeful about for the post-pandemic wave? What makes you hopeful? Is there anything positive that you've seen come out of this?
So I'll take it first, I guess, since no one else was jumping in. I think we've really kind of said it. I think, you know, never let a good crisis go to waste. You know, it's hard to make change when things are sailing along smoothly. When things get a little rough, that's a time you can rally people to change. So as we've discussed, telehealth, potentially changing the way we use our in-office, whether it's physicians or support staff. And the other thing I'll say is it has been a morale issue, I think, for physicians and for healthcare providers, certainly across New York. I spent a lot of time in my job dealing with physicians and talking about physician burnout. I honestly haven't heard that term for the last 4 to 6 months in the same way. Burnout for maybe working a lot of hours, or that's, you know, people in Caramount who volunteered and helped out on inpatient. It brought kind of more that sense of purpose for what we are doing, you know, that true call to help people. And I think it brought the organization together well, and it brought the whole medical community together well.
Well, that's really good to hear. Yeah.
I would just double down on that. The sentiment from my hospitalist colleagues at Cornell amidst all of this was like, oh, I'm so happy that I'm a physician and I can help in this scenario. And I think that's true for all healthcare workers. And as Rich was pointing out, burnout in healthcare is a very real issue. And there's sort of a return to the sense of mission that caused people to go into healthcare in the first place. And my hope is that this is not just a several months feeling for everyone, but can be a sustained thing.
Yeah, I think the thing about teamwork can't be understated. I think that, and I think that we've created teams that we never thought we could create. We've put doctors together with different specialties together with different nurses with different specialties, and we've put all sorts of teams created overnight, and they have been enormously successful. And I think that sense of what we can do, we will not lose that momentum. I think the other thing for us in particular is that NYP, Weill Cornell, and Columbia are stronger as an enterprise. We've collaborated more than we have ever collaborated in the past, and that is not going away. That's staying here for forever. So and so I think we are much stronger, having seen what we can do, and that our resilience is probably, as many others across the country, is really encouraging and amazing.
Well, that's a wonderful note to end on.
Mm-hmm.
So we're just about at 3 o'clock. I want to thank Rich, Ryan, and Emmy for a great discussion. We will be releasing the webinar for those who asked. we have a few questions. Maybe I'll send them to you guys if you feel like answering them. But thank you so much. This was really, really insightful, and I look forward to connecting soon. Take care.